Hello, and thank you for joining Moving Forward, the 2012 HHQI National Campaign Welcome Webinar. We're so pleased that so many of you have logged in to learn more about the exciting enhancements to the HHQI National Campaign as we formally launch our third phase of improving home health quality today, September 18th, 2012. Now, to welcome everyone to today's webinar, I'm pleased to introduce Cynthia Pammon, who is the HHQI National Campaign Government Task Leader for the Centers for Medicare and Medicaid Services. Cynthia?
Hello, everyone, and welcome to the kickoff webinar for Phase 3 of the Home Health Quality Improvement National Campaign. We here at CMS are so glad you joined us today on the webinar. And in Phase 3, we are striving to create a campaign that is both clinically and operationally relevant and effective. We hope that the resources and tools provided through the campaign will assist you with providing quality care to your patients. We also look forward to your active involvement and engagement in today's webinar and in all of the campaign activities in the near future. With me today is Jean Moody-Williams, Director of the Quality Improvement Group in the Center for Clinical Standards and Quality here at CMS. In addition to being a published author, Jean is a registered nurse and champion for healthcare quality in all healthcare settings, including home health. I will turn the mic over to Jean to say a few words to you. Jean?
Thank you, Cynthia, and I'd like to thank all of you for joining this call this afternoon. This work is very important, and I think that you are going to really enjoy the webinar as you hear from those in the field who are actually experiencing the benefits from prior campaigns and know how important it is that working together, we collaboratively will improve the care of patients. The thing that I really wanted to point out is that your work is so important to really achieving some very significant national goals. You're probably very familiar that the Secretary of the Department of Health and Human Services has charged us all to improve the safety of patients, to reduce the number of healthcare acquired conditions, and much of the work that will be done through this initiative, such as reducing unnecessary hospitalizations or working on the management of oral medications, really are fully focused on improving the care that patients receive and improving the experience that their families have as they go through the care processes with them. We're also very much concerned about matters of prevention as we look at flu and pneumonia, and eventually looking into other areas of population health that we know that you all can have a definite impact on. And of course, the reduction of healthcare disparities is key as we do all of our work. More recently, we have had a focus on patient and family engagement, and we think, when we consider that you're in the homes, that you're interacting with families on a daily basis, that we can actually learn a lot from you on how we can best go about improving and activating patients as they try to navigate their way through the care system. So I'm going to stop because I know the program that's ahead of you, and I want you to be able to jump right into that. And I encourage you to fully participate, ask lots of questions, and we're just here to support you in the work that you do to improve patient care. And I'll turn it back to Cynthia.
Thanks, Jean. And with that, we're going to get going and get started, and we look forward to hearing more from you in the future. And I'll turn it back over to Shannon.
Thank you, Cynthia, and thank you, Jean. We really appreciate both of your comments, and it's a great way to kick off a very exciting live webinar broadcast session today. As you all mentioned, we want this to be as interactive as possible, so please, if anyone participating today has any questions or comments for any of the presenters that you're about to hear, please send them via email to hhqi@wvmi.org at any time. You don't have to wait till the end of the session. As soon as that question pops in your head, go ahead and open up your email function and hit send, and we will get to as many questions as we can at the end of today's session as time allows. Also, handouts from today's presenters will be posted online at homehealthquality.org by the end of this week, alongside of a recording of today's session. So if you like what you're hearing and would like to share it with others, or even hear a replay of it, you'll have that opportunity by the end of this week, and we will notify everyone via email of the availability of both the recording and the handouts from today's session. Next up on the HHQI Welcome webinar, we'll be discussing the evidence-based resources that the campaign provides free of cost to all participants. Here to tell us all about it is Lead RN Project Coordinator Eve Esslinger. Eve?
Thanks, Shana, and hello, everyone. I'm going to be sharing with you the schedule and plan for the Home Health Quality Improvement Phase 3 Educational Resources. We're going to continue with the best practice intervention packages, or the BPIPs. The packages have truly been a good resource for many, starting with home health providers and now used by other providers as well. In fact, for the Phase 2 BPIPs, there were over 150,000 BPIP downloads. That's pretty amazing. We know the BPIPs are being used, but we are going to make some format changes to meet the needs of more agencies for Phase 3. The first thing I would like to do is a brief review of the past 2 campaign packages. As you see in Phase 1, for those of you who were active in that campaign, you'll remember we had 12 packages and they were monthly. And then for Phase 2, which started in January of 2010, we had quarterly packages, 6 packages, and we posted those up through April of 2011. Now for Phase 3, as you see, we have 8 packages planned. Now, what we know is that the best practices continue to be the best practices. The best practices haven't changed. For example, we know that fall prevention, improved medication management, and better disease management, those are just examples of best practices. They all prevent hospitalizations. But we also know that the work of implementing BPIPs is ongoing, and we need to get the best practice tools and resources into clinicians' hands so they're used. What we decided to do for Phase 3 was to develop an abbreviated, or what we called focused, BPIP for the topics of patient self-management, medication management, disease management, 2 parts, fall prevention, and cross-setting care. The release dates are on the screen, and as you see, the first of these, patient self-management, will be published on November 1st, 2012. The packages will be about 15 pages in length and even contain most of the tools. The topics are not new, as we just said, so you'll see some tools that you may have seen or even used before. However, I caution you, they're not the same tools. They've been updated. We've looked at them from health literacy concerns and also updated them. There will also be at least 1 new tool in each package, so kind of something for everyone, even if you've used a lot of the resources. The focus BPIPs are ready to be turned over to the hands of clinicians. They're short, attractive, and contain information for just about everyone. I think you will all like them and appreciate the new format. The previous BPIPs from the previous campaigns are also still available, and I'm going to show you where you can find them in just a moment. Most of the information is still current. In fact, I would say probably 99% of it. So if you're looking for more information than you're going to find in the focus BPIPs, consider going back to one of the previous BPIPs. There's tons and tons of information in those BPIPs. We'll reference and link to these BPIPs from the focus BPIPs when it's appropriate also. We'll have 2 additional BPIPs for this campaign, not focus. These are more traditional, and we're going to call them primary, and you'll see the packages and the release dates, dual eligible provider and immunization. Dual eligible provider is a topic that Ms. Dikevich will discuss later on in the conference. Now, we get lots and lots of questions about implementing the packages. And I would like to spend about 5 minutes giving you some tips and information on implementing BPIPs. To begin, the best practices are evidence-based. And our goal is to put the evidence in the hands of the clinicians in the form of practical guidance and turnkey resources. We want to work with our participants to make the resources adaptable, dependent on their patient preferences and values. You know, we always appreciate your input and suggestions. They're great. Please understand, and we get this question a lot, you can take our tools and adapt them and change them. You can add your logo. You could even add something more specific to your agency or specific to your patient population. And you certainly can add maybe directions for your staff on completing the tool. Use them and make them your own. And now just a few minutes on some absolutes on improving. Your staff needs your organization to commit to quality. Quality is not a once and done. It's a ongoing, 24/7 and 52 weeks a year. Keeping quality at the center of all agency processes and making sure quality is actively reflected in your mission is so important. You need to have the type of culture that promotes quality, one that learns from errors or potential errors, and one that focuses on improving processes. What I'd like you to do is to ask yourself, when you have a patient hospitalized, what happens? It should be a team effort to look and see if there were perhaps missed opportunities. And note that I said missed opportunities, not mistakes or errors. We have to see them as missed opportunities. Are there things that you could do different next time? All of you. It's important to see also if your agency has the processes to make it easy for the staff to work on avoiding unnecessary hospitalizations. It was interesting that a recent publication called, and I'll tell you the name of it, it's the Delta Study to Reduce Hospitalizations, a national study to reduce avoidable hospitalizations through home care. This was shared last year at the National Association of Home Care Conference in October, and it was also posted or published around January of this year. And this study found that agency awareness and support was the second most frequently used strategy to prevent hospitalization. The report states that, and I'm going to quote here, agency awareness and support is making sure everyone in the agency knows that preventing hospitalizations is important and knows the ways in which the agency is trying to address the problem. That's so important, and truly it is an organizational commitment. I also have listed ongoing staff education. I urge you to take advantage to learn with your staff and share in their successes. Use our resources here at HHQI. Use our data. Use our information. A lot of this takes practice. I have practice, practice, practice. It's ongoing, and also communication, a lot of communication. And speaking of communication, keeping communication lines open between disciplines, between other providers, and especially with the patient, caregiver, and family. These are all keys to being successful. And you know, it's so easy for me to sit here and for us all to talk about improving communication, but it's not so easy to practice at it. Sometimes we have to break old habits, but we really do need to work on it, to practice, to make it better. Now what I'm going to do is go through some slides from our updated website and share with you how to find the BPIPs. I bet most of you know, but I just want to go over a couple of things that might be helpful to you. Number one, make sure you're registered and logged in. Shannon will go over that later. But then when you are on, go under Education in the toolbar. If you click right on BPIPs, I'll show you where you'll end up on the next slide. But before that, if you have a specific BPIP you know that you're going for, and I like to get to things quickly, I can just go and pick the BPIP I want and go straight there. But if you're going to click on the BPIP screen, or BPIP link, I'm sorry, what you would see on this screen is all the BPIPs listed. And all the BPIPs will be housed in the same area. So when we start releasing the new BPIPs as of November of this year. You'll see them here also. Then what you will do is then at this point you can kind of peruse, see what you want to use. What I wanted to show you if you click on down at the bottom, fall prevention BPIP, I have kind of a method to my madness here of why I want to show you the fall prevention BPIP. We'll go to the next screen. This has all the BPIP and all the resources associated with the BPIP. And down at the bottom is the fall risk assessment with algorithm. And our guest speaker, who I'm going to introduce in just a moment, uses that form, and she will tell you about that. So speaking of our guest speaker, we have with us Gail Batson. She is a nurse quality coordinator at Harmony Home Health in Natchitoches, Louisiana. And I'd like to tell you a little bit about Gail. And I want to, what Gail's going to be doing is sharing with us how she found the BPIPs and how she applies them. Gail graduated from a nursing diploma program in 1969. Gail's worked many years in multiple provider settings, serving as hospital nurse, OBGYN clinic nurse, nursing administration and long-term care, hospice staff nurse, hospital supervisor, and since 2010, she's been the quality coordinator at Harmony Home Health. Gail furthered her education by earning her BSN and MSN while working full-time. Gail's married to her high school sweetheart, has one son, a wonderful daughter-in-law, and is the proud grandmother of two lovely granddaughters, ages 13 going on 30 and 9 almost. Gail's favorite place in the world is her hometown, and I'm going to share with you a little bit about that on the screen. Her hometown is, and this is very interesting to me and for all of you who are movie buffs, was a setting for Still Magnolias, The Horse Soldiers, and The Man in the Moon. When Gail isn't working and in her home, she is relaxing in Panama City Beach, Florida, her second favorite place in the world, where she rests, relaxes, and recuperates. So I have a picture of Gail for you on the screen, and a very interesting picture of, yes, snow in Louisiana. I didn't think, living up here in Northeast Pennsylvania, that was possible, but it is, rare occurrence. So I would really enjoy and appreciate introducing Gail to you now. Gail?
Hello, everyone. It's a pleasure to be here today, and I just really wanted to let you know that I was honored to be asked to participate in this webinar. It's just a real fun thing to do, for one thing, and anytime you can educate is a good day for me. Yes, it does snow in Louisiana, and this is from a view from a window in our office, and it was a beautiful one-day snow, and then it went away. So that's about all we get every couple of years. What was going on here at Harmony Home Health when I came was sort of a lack of a quality program. They did have a utilization review and an audit system, but there was very little in the way of processes improvement. It was a lot of numbers, as Ria will allude to later. There were numbers, but there was really nothing to progress from having these numbers. So as it was a new position, the administrator told me that I would be developing and evolving this program. So actually I was starting from scratch. Once I got familiar with the systems here at Harmony and the people, and generally what had been progressing or had been processing here, I thought, well, what am I going to do next? And so I said, well, do like everybody else in the 21st century. You Google it. So I typed in quality, improvement, and home health into the browser. And guess what the first thing that pops up on the list was? It was HHQI. So that's how I found HHQI, and I said, well, this is right up my alley. So I clicked on that, found that it was very easy to register. The site was very easy to navigate, user-friendly, easy to browse through all the different aspects of the HHQI programs. What I didn't really believe at first was that it was free. So what's the catch? Because there's usually a catch. So I registered and signed up, and I was looking around in the site, you know, what's it going to cost, that sort of thing, and it doesn't cost anything. It's a wonderful service, and as Eve also said, we're all here together to improve and the quality and the access to care. The BPIPs was just what I needed. I was browsing through the site, and I saw some of the packages. Like I said, I started a little late after the actual Phase 2 had started, and found a couple of tools that I thought would be good to help improve our systems here. And the fall risk assessment form was the first thing that I saw. And it was a really concise, clear, very detailed fall risk assessment, which our assessment had been rather vague and didn't give as much information as I thought it should give to make decisions about how to prevent these falls. So I really enjoyed the fall risk assessment. The exciting thing was when I found it, I flipped it over, and there was the algorithm on the back. And so you have all this information, and now what do you do with it? So there was the algorithm, and if you have certain patient has certain difficulties, mobility issues, incontinence, and that sort of thing, then you can just look at your little box and follow the algorithm, get your physical therapist involved, your social services involved, whoever you need to get involved in this fall risk prevention. So I said, well, this is just really handy, and it helped us plan and activate a good program for fall prevention. The nurses, the staff nurses, were actually given the fall risk assessment form to look at and to read over and kind of give us some input about how they would like to change it, if they would like to change it, and they did. They made a few changes in the assessment, and what would they do differently, or what would they add to it. So you need your staff input. As Eve also said, it's invaluable to get staff buy-in to go along with the changes. Then we were concerned about medication management. That was sort of an issue. We had paper system at the time, medication management. So there's a tool, or actually a section of the skilled nursing track in the medication management that actually gives you a checklist of how to properly do the medication reconciliation. Gave this to the nurses and said you really need to be doing 99.9% of the things that are on this checklist, because if we're not, we're really not managing the medications very well. And as everyone knows, medication management, most of our patients are polypharmacy, have multiple medications, and go to the hospital or go to the doctor, get meds changed, that sort of thing. So you really have to keep on top of the medication management. And I passed that out to the staff in our, we have weekly staff conferences, and I try to pass a few things out as often as I can. I don't want to overload them, but they seem to enjoy the fact that they had something to refer to be sure that they were getting all the their bases covered when they were doing their medication reconciliation. Also, I really, really, really like the emergency care plan, and that is in your section over here, and I'm actually looking at it, but the emergency medication plan was really something that I thought that our patients could utilize, that our nurses could utilize for our patients. Sometimes we have low literacy patients, and they have a hard time following just written instructions, black and white piece of paper that you give them that tells them do this, do that. So when I printed these out and showed them to the nurses, it actually has a little illustration there, like I hurt or I'm having trouble breathing, and has little bullet points which really focuses in on what the patient's problem is. And first it's call your home health agency when, and then when to call 911. So that helps the patient and the nurse sort of decide exactly how they're going to proceed with the patient and keeping them out of the hospital. We've talked about that a little bit earlier too. hospitalization. So the emergency plan is something that we've started using, and I really do recommend that for everybody. And you can download that. That is just so nice. You can download it, put your agency name and all that in there, put your patient's name in it, go to the section that you're interested in, say, for instance, fever above. And a lot of patients think 99.2 is a fever, so you can put a fever above 100.4, call us, and fever above 101, with so forth, call 911. So that helps the patient understand when they need to call us and when they need to call 911. So those were just invaluable tools, and I only have 3 of them there that I've really focused on because you don't want to overload your staff. You don't want to overload yourself. You can't throw a lot at people all at once and expect you to have a good job. Some people pick 5 or 6 things that they want to work on, and that's just way too much, and you're going to frustrate yourself. It's like teaching a pig how to fly. You frustrate the pig, and you can't do it. So don't overload your staff or yourself, and you'll be much happier with your system. Just a few practical tips that I found. I have a little philosophy, and I call it my marketing philosophy, actually. Of course, most agencies have marketing and handouts and things that they like to do to try to attract patients and have doctors and providers refer to them. But I think that if you build it, they will come. In other words, if you build in the quality to your agency, the patients will come to you. The doctors will refer to you, like the Field of Dreams. So that's what I like to think that we're doing here at Harmony Home Health. We're building in the quality, and they will come. And, of course, it's always a team effort. You have to work closely with your administrator, and the director of nursing and the assistant director of nursing, of course, are all on board, and we work together with these projects. You have to make an effort to coordinate. It isn't easy. It isn't necessarily easy, but it is necessary. Coordination is the key. You have to be sure that everyone's on the same page and that everybody has the same philosophies and the general idea of what you're trying to accomplish. For instance, coordination with the hospital. Now, we only have one hospital here in Natchitoches. It's a small town, smallish town. It's a university town, but we have one hospital, and I called and spoke to the quality coordinator there, which I had already known before she was quality coordinator, and we spoke several times. We emailed back and forth, and she was very interested in some co-ventures in services. She asked me to come over and speak to give an in-service about what we were doing and how this would benefit both the hospital and home health agencies. We shared some tools. There's another good organization called H2H, or Hospital to Home. We shared these things and how we can better serve the patients that they're our patients. They're not my patients. They're not her patients. They're our patients. We see them in the home, and they see them in the hospital situation. So we wanted to coordinate our efforts, and sometimes it's not easy, especially if you don't know the people, but you really do have to reach out, because if you're sitting there waiting for somebody to get in touch with you, you may be sitting there for a while. Louisiana is one of the highest hospitalization rates in the country. So we have to coordinate with our other providers to overcome our high rate, and that's one of the things that I'm really working on here at Harmony Home Health. I have a little program that I try to review the transfer forms, the visit before the transfer, and the visit after the patient gets out of the hospital, and of course also the hospitalization records, to see, as Eve said, if I can glimpse an opportunity that we might have missed. And you don't want to call them an error or a mistake, because retrospectively it's always easier. Hindsight is 20/20, to see what you may have missed and share this information with the staff. And so hopefully that's a little bit of education that will benefit not only the patients but the staff as well, so they can get more confident with their you know, when they say, well, this is a little different or that's a little different, but it's really not that bad, but it may be that bad for that patient, and you have to individualize your assessment to coincide with what's been the routine findings in your patient. So as I said, Louisiana is one of the highest hospitalization rates in the country, so we really need to start working on getting that down. Also, we sneak in a little education during our staff meetings or our case conference meetings. Nurses, especially home health nurses, are busy, and they don't want to sit still long. They have places to go and people to see. So instead of trying to present some long, boring PowerPoint presentation, I try to just give them a little bit here, a little bit there in our staff conferences. I call it baby steps. Give them some handouts, give them some of the tools to read, and get back to me with any opportunity that they may think would be any changes or anything that may be beneficial to the system here. So they don't sit still long, and you have to know this and plan appropriately. If you tell them, well, they have an hours-long presentation tomorrow at 2 o'clock, they go, oh. I got patients to see, I got this to do, I got that to do. So you also need to be reasonable about, excuse me, the number of tools that you throw at them and the changes that you make at one time, because resistance is futile. They have to know that, you have to know that you may meet resistance. For sure, if you try to make too many changes at one time, you need to take that in, as I said, little baby steps. You have to encourage and solicit the feedback that you're going to get from the staff, and tell them that anything they want to tell you, you know, we'll write that down, we'll put it in the list of things to do, see if that works for you and it works for us, and, you know, we can use those suggestions. You have to really be open for all of that, because staff input, not just administrative support, but staff input is essential for progressing in your program here. For instance, we did circulate that fall risk assessment and got the staff feedback, and that's how we came up with our final tool. So as I said, be open, be honest, don't give in, because if you do, you're destined to fail, and the only time that you don't succeed is when you quit. So there's a Don't Quit poem you might want to look up online. I don't have it right here in front of me, but I used that while I was getting my master's degree. So it's the Don't Quit poem. So in other words, as Henry Ford would say, and I saw a reference to Henry Ford, another quote earlier in the presentation there, if you always do what you've always done, you'll always get what you've always got. So you have to plow on, keep going, don't give up. You can do it. So that's just a couple of little tips from the folks that are in the real world here. And, you know, if you don't do it right the first time, it's okay. You can just scratch that out and do it again and see if it works a little bit better the second time. So like I said, I'm really happy to be here. It's a nice, cool day in Louisiana for a change. Going to be a lovely afternoon. So I hope you've enjoyed this part of the webinar, and there's a lot more good stuff to come. So y'all stay tuned. Don't go away. You'll want to hear the rest of this. And I really appreciate, again, being asked to be here. So y'all send in any questions that you may have, like they said earlier in the program, and we'll be glad to answer them for you.
Thanks so much, Gail. That was a wonderful presentation. We here at HHQI appreciate what you've had to say so much, and I know that our participants do too. So thank you so much.
You're welcome. Thank you.
I do want to tell participants, if you are interested in the resources that Gail went over, I did put those on slide 16, the location, to help you out, or email us. Email me. We'll help you find those. At this time, I would like to turn things over to Cindy Sun, one of the nurses here, nurse project coordinator at HHQI. Cindy?
Thanks, Eve, and hello, everyone. So now we'll move into the data portion. And talking about first, what are the data reports that HHQI has available to you? First of all, they are 12-month rolling reports, and the data comes from the OASIS data that you transmit to CMS. So this is not risk-adjusted, it's untreated, and it is not the same as Home Health Compare, where Home Health Compare is risk-adjusted data. This data is raw, and for that reason, there are some security issues involved, and we'll talk about those in just a few minutes. Now, currently, the two particular focused reports that we have are ACH, or acute care hospitalization, and the oral medication improvement rate. As I mentioned, it dates back to 2009, and these are updated around the 3rd week of every month. Now, this just means that if your agency was a CMS reporting agency in 2009, you probably have reports just waiting for you. All you need to do is access them. Now, as with everything else on HHQI, everything is free of cost, and it's free of obligation. To access those reports, just go to the HHQI website and click on the Data Reports tab, and it will take you into the data portal. Once you're here, you'll notice in the center of the page there is the registration and login links right there. You can just, if you have an access, that's fine, and if you don't, you can create one. The big thing to remember with this login and registration is this is completely separate and unique from the general access login and registration, which you were just told about through Eve and Gail's information. So there's one where you can access the best practice packages and tools and resources, and then this is a separate one. It's important to notice so that you don't get them mixed up, but it is for the security of your report. So the first report we're going to talk about is the ACH report. Just going to take a second or two to run through it. I just want you to have an idea of what is available on the site for those of you that haven't accessed it before. You notice in the first report, this is the ACH report. The title is there, as well as the date that it was actually published. At the beginning of each table in the report, it's about 7 pages long, you'll notice that the hospitalization versus transfers and discharges, the information of where this data was collected is listed at the top. You'll notice in this one it's excluding planned hospitalizations. Now, for those of you that are interested in historical trends over the past few years, dating back to before the implementation of OASIS-C, the ACH calculations including the planned hospitalizations, that's available at the end of this report. Just like I said, it's for historical trends. The information I want to share with you now is just to let you know that this is different from the 30-day readmission rate. We're asked about the 30-day readmission rate because that's what the facilities and other healthcare providers in your neighborhood and communities are probably asking about right now. The ACH rate is calculated based on any time a patient was discharged from your agency. I should say not a patient discharge, but any time an episode of care ends in a hospitalization. So it is different than what the facilities are talking about. And I just wanted to make that clarification to help you out for when you are discussing and dialoguing with your facilities. Now, in addition to the hospitalizations, transfers, and discharge calculations on this particular table, you'll also find that the state and national ACH rates are there for comparison purposes. So in our fictitious agency, we can see that this agency started the year with an ACH rate of 30.9% and then improved over the next 12 months and brought their ACH rate down to a 24.9%. The last column on the right shows that it's a 26.3 ACH rate for the year. As I mentioned, these are 12-month rolling reports, so you can see this was the June data. Just a couple of days ago, the July data was posted, so it's available for you now. Another report that you might find helpful is hospitalizations by days of the week, looking at the idea, just looking in particular, was there a certain day of the week where your patients had more hospitalizations, or was there a day of the week where there were fewer hospitalizations? And if there was fewer hospitalizations on a certain day trending throughout the year, what's going on that day, and are those variables and factors, can they be moved to the other days of the week? The next report, it's my favorite report, looking at reasons for hospitalization. Now you notice that this information is coming from M2430, and this is really a table where you can drill down and see if there is a particular disease process that might be causing your patients to go back to the hospital, and this might be an area where you want to focus your improvements. And I just wanted to point out, I'm sure that everybody is addressing the other than above category on this particular question, and this is a table of where you can watch it on a monthly basis. All of your efforts going into reducing that other than above option, it'll be displayed on this table. This is the graphic and the visual in case you want to share your monthly information with your with your staff, but you don't want to put the raw data out on the bulletin board or something. This is a nice visual of what you can just cut out and post to keep everybody informed of what's going on with your actual rates. The other tables included on the ACH rate table, on the ACH report are age, race and ethnicity, payment source, falls prevention intervention. The real question is, did any of these play a role in the rate in which your patients were hospitalized? Now we'll just take a second and look at the oral medication report, because we all know that oral medication mismanagement is a frequent cause of hospitalization. The first table, it does look at the overall improvement rate of how your patients improve while in the care of your agency. We're looking at, again, the discharges and how many of the discharges did show improvement. That is how to calculate the rate. And then also, as with the ACH rate, we're looking at state and national averages on here as well to give you something to compare it to. Now, again, on the fictitious agency, we can see they started the year with a 47.5% of their patients leaving the agency showing improvement in the management of their medications while under the care of the agency. Over the next 12 months, we can see that the agency increased to 51.3% of their patients improving in the management of their medications. And again, with the state and national rates, we can compare and see that this agency did a little bit better than the national rate, but then they were a little bit lower than the state's rate. Other tables that are included in the oral medication improvement rates include the medication follow-up. Did that impact the improvement rate? High-risk drug education. Did that impact it? Race and ethnicity. How about age? The question is, if they impacted it, positive or negatively, the data is just to help focus your efforts on that. Coming soon, we're going to include risk-adjusted data as well as a brand new report looking at immunization rates. So the data reports are here simply to provide evidence of where you may want to focus your improvement process, but only you at the agency and in the patient's home can actually decide the true picture. So HHQI offers different areas of support to help answer not only your questions on interpreting these reports, but also what steps should you take next. If you go back to the main page of what we call the data portal where you originally logged in or registered, you'll notice in the right-hand side on the upper right corner, there's a link for questions. Here you'll find guides and webinars to help you with the interpretation of the reports as well as a few next steps. Another good link is on the left-hand side. The FAQs are found there that may have some answers to your questions. And finally, if everything else fails, please feel free to contact us through either of these two links. We'll be happy to either provide answers via email, or if you prefer, we'll be happy to arrange a phone call and go over the individual reports with you. As it's been mentioned here before, we're here to help. All we need to know is what can we do to help you with this. We know that these reports are not going to do any good if they're not being used, so let us know what we can help you with. The final link I wanted to show you on this page as a resource is for Access Plus. This is a system developed for those wishing to access the reports of more than 11 agencies every month. The idea is the system will help you not have to log in to all 11 reports every month. If this is something that sounds of interest to you, just contact us and we'll be glad to walk you through the steps. Now I'm very pleased to introduce Ria Rodriguez, who will speak to how her agency has utilized the HHQI data reports. Ria was born and raised in the Philippines in the capital of Manila. She shares that her name came from the acronym of her parents' name, R for Rodolfo, I for Isabel, and A for always. Rodolfo Isabel for always. She received her BSN in 1991 in her homeland and then came to the United States in 1995. Ria has provided care in the Chicago area hospitals, rehabs, and long-term care facilities for 15 years in the capacity of supervisor, director of nursing, and corporate consultant before moving east in 2010 and joining the VNA of Maryland as the Associate Director of Quality Improvement and Education. Recently, Ria was recognized as one of the 2012 100 Extraordinary Nurses by the Honor Society of Nursing, Gamma Beta Chapter of Sigma Theta Tau International. Please welcome Ria Rodriguez.
Hi, good afternoon. Thank you so much. And it's my pleasure to be part of this campaign. And we can get started. I would like to share with you about the VNA a little bit. VNA Home Health of Maryland has been serving our community since 1895. We are dedicated to meeting the needs of individuals and families by providing compassionate, innovative, and comprehensive home health care services. And the next slide will show you some of our, there you go, our different programs and the rest of our staff. We have RN, PTs, OTs, all the staff that you could probably think of. We have it. But so let's get to the topic right now. I would like to share with you how HHQI plays a role in quality improvement of our agency. And there are several reports, as Cindy has mentioned earlier, of HHQI, but I only focus my attention to reports that would make sense to me. The following are some of the reports that I looked into every month: the monthly hospitalization, hospitalizations by day of the week, reason for hospitalization, and improvement in management of oral medication. I'm not saying that the rest of the reports are not important. It's just that I think this is what what I need to drive a lot of quality improvement in our program. First of all, just like a lot of you, I'm anxious to see the hospitalization rate monthly. And of course, I would always say, oh, no, will my boss be happy? Or he will ask me to call Cynthia and double check the result if it's correct. And really, this is what everybody wants to know. What is your hospitalization rate in the medical field? This is what your preferred provider wants to know, the doctors. So if you are just like us in our company, we're preferred provider by a lot of hospitals here, and they're very in tune to hospitalization rates, and actually this is part of what we share when we give them information on a monthly basis. So, but of course, as we know, this is not yet risk adjusted, and I said not yet because I'm pretty sure they're working on it. So getting back to the hospitalization rate, this report will drive different avenues for improvement process. There has been different improvement process that has been made in our agency looking into these numbers. So just, for example, what did we do about this number? We just don't look at the number. You want to plan on what can you do to improve these numbers. So one of the things that we have done is front-loading visits. Follow-up visits within 24 to 48 hours is very essential, especially if your start of care is on a Thursday or on a Friday. You know what happens during the weekend? Your patients will just, black out like they don't have nurses probably on the weekend, or my nurse is not working on the weekend. So it's very important that you have a follow-up visit to know and to see if your patient is okay. This is done especially for our acute patients, those patients that are like new to insulin, new to G-tube, new to a lot of medications. And the chronic diseases, we concentrate on our heart failure, our COPDers, our diabetes patients. So a lot is being done. I would look into, first thing I would do after I see my hospitalization rate is look into one of my audits. We have a lot of audits that we do in the facility, one of which is transfer to inpatient facility audit. What am I looking for in this audit is I'm looking at like 3 days before. Was there any signs of any, like, say, infection? Did the patient report anything that I feel sick, or I don't want physical therapy today because I really don't feel good? So those are cues. So that's what I'm looking for. If the provider or the nurse or whoever is in the case did write that, what did you do next? That's the next step. So was the physician made aware at all points that this patient is saying that I'm not really feeling well today? Before the patient went to the hospital, another thing is, did they call us? In the real world, we all know that not all our patients have their PCP. Who's their PCP? It's the ER. So they'll just go to ER right there. And if we educate our patients that you call us, this is a very big drive, I believe, to a lot of our agencies. And in our admission packet, it is there. We have this luminous paper that says, call us first. And I would look into the data. I would look into the stats if the patient is actually calling us first. We revised our admission process, our documentation. We have added in the system, we're electronic, so I've added in the system, like, did you instructed patient when to call the VNA versus 911 and the MD. So these are kind of like some of the changes that you will actually do, because you wanted to improve every time. You wanted that level to be not just stagnant. Our level is always, you want it to be higher every time. If you see your hospitalization rate is trending up, again, look at your audit, look at your utilization review audit. Look at when, if you're an agency that has your own staff for physical therapy, one of the audits that we have here is called the add-on discipline audit. This is, we look into if we're compliant within 48 hours, and we are. You'll see that. You'll share that with your staff. The SOC, the start of care discipline. Are you within 24 hours of starting this, starting the care? So these are important factors that actually was driven because of looking at your monthly hospitalization rate. So there are a lot of factors. There are a lot of improvements that you can do just by looking at one number. You just don't look at the number and then sit down and just wait for the next month, and maybe our number will go down. But what did you do about the number before that month? So that's one way. Also, our agency, because of the hospitalization rates that's going on, more than 90% of our staff is a certified integrated chronic care specialist, and I think this is something that a lot of you should think about, because this really would help your patients to help themselves to manage their disease process. It's a disease management thing. So that's that for the monthly hospitalization. As you've noticed, I've already talked too much just on monthly hospitalization, because there's a lot. There's really a lot of things that you can do by just looking at your numbers. There are a lot of things that can drive this number to improve the quality of care of your patients. The next report that I would like to share that I use is the hospitalization by day of the week. This is, I would say, I use this for two reasons. First is I really just want to see if my patients are trending. Are they going out to the hospital, or they're going to the hospital more on weekends or every Monday or every Friday. So I would look into that. Why are they going out? Why is this day so trending? And the other reason for me using this data is for educational purposes for my providers. If I say providers, those are everybody that's taking care of our patients out in the field. So I share this. We have monthly in-services for nurses, and our team meeting, meaning to say that every discipline will have to come to the office, and one of the things that I share are this result. So they see the graph, the wonderful, colors that they can see. They'll see that green bar is way up there about, let's say, every Monday or every Sunday. So they'll wonder, because these are actual numbers. I didn't make this up. So this is what you want to share with your providers, is that these numbers are real. These numbers, I didn't wake up one day and, oh, maybe I'll put this in. So no, it's really coming from HHQI. So when I was reviewing this report, I did then check during the weekend. Thank God, our weekend is really low. What I'm finding out is Mondays and Tuesdays. So you need to look into why. You need to look into when was the last visit done. So again, this would generate a lot of quality improvement that you can do for your agency. Look into the last 2 visits or the last 3 visits. When was that? So then you can adjust. So maybe you need to review your utilization review audit. So that's how I use. That's when also part of an audit that I do is, did they call us first or no? Or did they call us at one point and they said that I'm not really feeling well? What did we do about it? What did the triage? We have triage nurses. We're open 24 hours. Our patients can access and they're talking to a live person. They're actually our own nurses they're talking to. So that's really important that they know that they can call us anytime, any day. So you want to throw this out to your staff. What else should we do to improve, to lower down, rates particularly on Mondays? So maybe they'll say, maybe we should give them a call, or maybe we should visit on a Friday. We want to make sure. And one very important thing is you educate them to call us first. The next report that I look into is reason for hospitalization. This is search for real reason for hospitalization. This is another educational tool for the disciplines, for them to get as much information as they can. You can, because we're electronic, you can just click on, okay, this is what the reason of my patient going to the hospital. Again, if I show them the graph, there's going to be this red or yellow graph way so up that says other than above reason. So other than above reason is usually way up there. And the last meeting that I had with the providers are like, oh, that is really high. What are we doing wrong, Ria? So they'll ask you. So because again, these are real numbers. I didn't make this up. So you have to really know what the reason that they went to the hospital. We don't approve orders here that just says hospital hold, patient in the hospital, unless it's complete. It has to have a reason. It has to have the date that the patient went. So our providers are calling the hospitals themselves. What is the admitting diagnosis? And that's the only way that they can submit their TIF. The last report that I usually looked at on a monthly basis is the improvement in management of oral medication. This is very interesting because This information is given to the disciplines or to the provider, educational opportunity to instruct them, or an opportunity to say kudos to you because the rate is really very good. The patients are really improving. How patients improve in management of oral medication, it's how they educate the patient. So really they're going to see this. Oh, yeah, okay. So this is what you do. This is what you do every single day or every time that you visit your patient is education. Educating them about the medication, the purpose, the side effects, all those things. And I share them the results so they know. And then, again, I usually throw them the question as to how do you think we can improve on this aspect? Or if the result is really good, how do we keep it up? So it's a never-ending process. I believe that quality should never end. We should always strive for quality every single day, and that's what we do here in the VNA. And anytime that you have questions, I always email Cindy, or I call her, I bug her every month, and they will respond to you. They are very supportive, and they would give you information that you needed, especially if you're new home care, you're just starting right now. It's very, very helpful that you start using the reports that HHQI has. So that's all I have to say. Thank you.
That was a great presentation, and I hope everybody can, I'm sure everyone can take something from what you've shared because you covered quite a lot of information, so that was fantastic. And I'm also sure that there's many out there today with the same feelings of anticipation and concern and probably a little anxiety of opening your own data reports. Ria has shared some ideas of how to let the data guide your quality improvement process, but if you have other questions that we can help you with, as we've mentioned before, just let us know. Now I'll turn this over to Shannon Wright, the HHQI Campaign Director. Shannon?
Thank you so much, Cindy, and thank you to all of our presenters and attendees who are still with us today and attending the 2012 HHQI National Campaign Welcome Webinar. To kind of tie things together, I just wanted to provide a quick live demonstration of the HHQI website. I know both Cindy and Eve have provided some screenshots, but I thought it might be helpful, especially since we just launched this brand new website just a few days ago, just to quickly show you some of the frequently accessed functions on the website so you can make sure that you jump in and start enjoying these great free resources right after today's presentation or first thing tomorrow morning. First thing I just wanted to highlight, for those of you who are not already registered participants in the Home Health Campaign, there's a simple button, as you can see here on the screen, for registration. You just click on it, and it takes you to a simple form that you can fill out. It asks for information. If you're in a home health agency, we do need your CMS certification number so that we can adequately track that you're a participant in the campaign and that you're utilizing our resources. If you're not in a home health agency, maybe you're a stakeholder, allied partner, or in another setting that's not home health and you'd like to adapt some of our tools, you can simply click on the No button here and still register for instantaneous access to all that the Home Health Quality Improvement National Campaign has to offer. For those of you who are already registered participants from one of our previous phases, there's no need to re-register. Our brand new website does remember your username and password. So if you've already been participating, all you have to do is click on Login. It's at the top of every single page on the website, as you see here in the upper right-hand corner. And then when you log into the website, there's a great new feature called Remember Me. And that way you don't have to try to keep track of both your data access and campaign website information. The campaign website will keep you logged in. You can see here in the upper right-hand corner, Welcome Shannon B. Wright. That means I'm logged in. So now I can enjoy access to all the best practice intervention packages that Eve talked about. If you click on the Education tab, as you see here in the top of the website, that will take you to a page where we list the upcoming schedule of best practice intervention package releases, as Eve has detailed. Additionally, you can scroll down to the BPIPs and see all of our Phase 2 archived resources all here for you to access. Again, that's what you must be registered in order to view. So if you are not yet registered for the campaign, please, as soon as this webinar is over, go to homehealthquality.org, click on registration, and you can start enjoying these great resources. If you ever need help accessing the website, navigating it, or with anything else, you can always reach out to us at hhqi@wvmi.org, and we'll be happy to assist you as well. So in Phase 3, as we're formally launching today with this welcome webinar, we not only have a brand new website, we also have the new best practice intervention packages and educational resources that Eve mentioned. We have new data report enhancements that will be coming soon that Cindy had detailed, and another really exciting and groundbreaking component of the campaign, which is a key emphasis on small, nonprofit, publicly funded agencies, and or those that serve a high proportion of dual-eligible patients. Here to tell us all about this exciting new initiative of the HHQI National Campaign is RN Project Coordinator, Misty Kevich. Misty?
Thank you, Shane, and so much. I hope that you are all excited about the campaign as we are getting underway for this next campaign. Let me get my slide here. As healthcare industry, we continue to strive nationally towards better outcomes such as ACH, med management, and immunizations. We still have persistent and well-documented health disparities that are closely linked with social, economic, and environmental disadvantages. And on this slide, you can see some of the key differences that agencies find for some of their patients. Gender, age, race, and ethnic status. There are also language barriers, sexual orientation, gender identity, and religious differences. There also are validated differences related to geography, such as urban versus rural or even frontier. And there are specific regions in the United States that disparities are even greater. Poverty and low socioeconomic statuses directly impact health status, access to care, and many other health care needs. In the United States, we still have disparities related to lack of insurance, mental health, disabilities, health literacy, educational levels, and even decreased quality of health care for this underserved population. The statistics are astounding. Over significant differences for these factors related to risk factors, hospitalizations, and even mortality rates. The Department of Health and Human Services are working collaboratively across governmental departments of HHS, as well as leading quality organizations towards a goal, a nation free of disparities in health and health care. So how does health disparities and the third phase of this campaign connect? Well, we're going to be working on developing materials that focus on the issues for that special population of Medicare patients. We are very excited in this phase of the campaign to be addressing health disparities with an emphasis on special populations in relationship to ACH, med management, and immunizations. We will be focusing tools and resources towards many of the health disparities that I discussed in the last slide. Notice the circles on this slide. They overlap. In many cases, so do these special populations. Many agencies care for patients who are termed dual eligible because they qualify for both Medicare and Medicaid services related to their income levels and health status. This population offers a different set of challenges for home health as well as other providers to improve patient care and outcomes. Many of you are leaders at your agency, and you see statistics come across your computer or your desk every month. Are you able to break down the statistics and determine measures or best practices to overcome and improve outcomes for your diverse populations? As we have seen in different healthcare settings, many times dual eligibles receive care from a variety of providers and even different services from both payers. Minimal coordination may occur. Fortunately, we are now seeing changes to a more coordinated patient-centered care for this special population in many states. Each state has different programs or expansions of programs to meet and begin to tackle this ever-growing problem. Some examples include CMS's Innovation Dual Eligible Integration Project, CMS's Medicare Special Needs Plan, Health Home Option with Medicaid Managed Care Organizations, PACE, PDA waiver programs, and there are more. Also across the country, there are home health agencies that are located in underserved areas that find improving ACH, med management, and even immunizations very challenging, related to some of those factors that we saw on the previous slide. Urban areas have a unique set of problems versus the very remote areas in this country. In this campaign, we're going to focus resources and opportunities to share innovation and ideas for improvement and strategies that are geared for the underserved areas. Another special group, another circle on the slide, is for those small nonprofit home health agencies where they have limited resources and find it difficult to implement the tools and resources at their agency level. Phase 3 of the campaign is going to allow us to work closely with those agencies, provide more one-on-one assistance in creating plans to overcome the barriers or issues that they encounter, preventing them to be successful with implementing the campaign materials. Over the next few slides, I'm going to give you a glimpse of different ways that we are going to be able to assist the agencies to see this special population patients. With that being said, that's actually every agency on this call. Each agency will have their own unique special population issues, but they are similar to either other agencies down the road or agencies across the country. The campaign materials being developed are for Medicare population, but they will work for any of your payer sources, not just Medicare patients. So let's start to look at some of those key ways that you're going to be able to receive education and support. The dual eligible BPIP, which will be released February 1st, 2013, will be a full BPIP package, a much larger version than the focused BPIPs that Eve mentioned earlier. The SPAN BPIP, which is the Special Population Assistance Network BPIP, is going to include many tools and resources for agencies used to improve awareness, knowledge, and solutions for issues that you find with your special populations. Additionally, we're going to explore different models of care or demonstration projects focused on those dual eligible patients and strategies to advocate and be proactive for our patient outcomes. We will be providing ideas of how your agency can work effectively with these types of organizations to improve coordination of care and maximize patient resources to reach those patients. Additionally, there will be information, tools, tips, or other resources that will be beneficial to the special populations in every BPIP that will be focused on those special topics. We are reviewing all patient tools or handouts for health literacy, plain language, and that's removing that unnecessary medical jargon. We're looking at reading levels, etc. So you may even see slight differences in tools from previous BPIPs with minor but significant modifications to improve readability and understanding for the patients. Learning how to use available data is another way the campaign will be assisting agencies. Consistent disparity data is very difficult to obtain in many of the social, economic, and environmental areas. But we'll be sharing as much data or data resources that may assist agencies from a national, state, and or even a county level for some of the disparity areas. Of course, the HHQI data reports include race groups that Cindy showed you earlier. And we're going to try to provide you with some additional data for this special population as we progress. We will be sharing interventions and strategies on how to use this data and determine the agency's area of needs and assist them with their quality improvement plans. Here is a sample of the data that's already included in the HHQI campaign reports for ACH. This breaks this down by race groups for your agency based upon the OASIS item M140, race and ethnic. We will be providing strategies to use reports and additional national, state, county data for quality improvement efforts. A new feature for this phase of the campaign is the SPAN networks. We're going to be establishing different SPAN groups related to different disparity issues or concerns. Now, these networks are going to allow anyone who wants to join them to share barriers as well as successes or knowledge. These groups will provide feedback related to tools or resources that will be offered to assist agencies to improve care and outcomes with this special population. You're going to be hearing more about the SPAN groups over the next few months and how to join. In the meantime, if you have a specific issue or even solutions that you may want to share with us now, please contact us at hhqi@wvmi.org. That's hhqi@wvmi.org. And mention SPAN or dual eligible in the email, and I'd be very happy to contact you. I hope that I've given you just a taste of what is to come with the Special Population Assistance Network. Watch out for more information through our electronic communications. Once again, I hope that you are just as excited as we are as we kick off Phase 3 of the campaign. So I'm now going to turn the presentation back over to Shannon.
Thank you so much, Misty. Now we have time for a few questions for our presenters. The first question is for me and asks, when can we sign up for Phase 3? The answer to that is a simple one. You can sign up right now. We've continued open enrollment for the campaign throughout its duration. So if you're not yet signed up to participate, please log on to homehealthquality.org and we will get you registered instantaneously. The next question asks, have you been able to demonstrate improvement in ACH rates at any of the organizations based on their use of the BPIPs, specifically cross-setting BPIPs related to transitions of care? That is an excellent question, and I can answer that yes, we have been able to demonstrate clinical quality improvement through agencies with a high level of engagement in the campaign and utilizing campaign resources. We have a very comprehensive final report that details that information, and that information will be peer-reviewed, published soon. So once we have that publication identified and that information out there, we will make sure to let everyone know so you can learn more about the demonstrated clinical quality improvement that a Home Health Quality Improvement National Campaign participating home health agencies have shown. Our next question we have is for Eve, and this question is from Tiffany in Nebraska, who asks, one of the speakers talked about organizational culture. Do you have resources on improving culture? It seems like most of the information on healthcare culture is for larger organizations such as hospitals.
Tiffany, that's a good question. We do. And I do agree with you. Especially in the literature, when you read about culture change, it is geared towards hospital. I will tell you that most of that can be adapted to home care. We do have in the BPIPs from the last phase, Phase 2, there are at least in 3 or 4 of the BPIPs. Sometimes I get a bit mixed up of what we put where, but you'll find like a 1 or 2 pager specific to organizational culture. We introduced culture change such as just culture, human factors. So those are very specific to home care, and if you need trouble or have trouble finding them, email us, and we'll definitely get those out to you. But that's a good place to start. But I also would look at the literature that's out there and definitely use that as it applies to home care as well.
We have another question for you, Eve. This one's from Sheila in Washington State, who says, our agency has been sold and there was so much turmoil for a while that we didn't work on anything. Our data has gotten much worse. I guess my question is, where should we start?
Well, that's a tough one, but it's kind of a good opportunity too. I think I would go back to where you were, look at your tools, see what was working, talk to your staff. And Gail, I would use the tips that Gail put on the screen, or Gail talked about when we had a screen, those tips from Gail. Gail started in 2010, starting as a new quality position at her agency, and I'm speaking for you, Gail, I hope you don't mind. And started.
No, I don't mind.
No, and I think do what Gail did. Look for those resources. I think it's good to define what your problem areas are. I would get a hold of those data reports for HHQI as soon as possible. Get registered. Look at those reports, the ones that Cindy's described, and try to drill down your problem areas too, because you may, based on those reports, see where you've got a problem. And if you don't, based on the reports, you need to get your staff to do the data, get the data to you better. Get the reasons they're being hospitalized. But great opportunity there. I know it's tough to start again. So thanks, Gail, for helping me out there too.
No problem.
Well, next up we hear from Josie in Oregon, who has a question for Gail. She says, hi, Gail. Thanks for your story and your tips. My question is that you talked about not overloading, just to do a few things at a time. How many changes do you make at once? 1 tool a week, a month? What would be a general rule of thumb?
A general rule of thumb, I think there would be I like to play it by ear. I know that sounds rather vague, but sometimes you just sort of have to feel out the goings on there in the home health agency. Some weeks are busier than others. I had a really good presentation, brief. I don't usually go more than 10 to 15 minutes with my presentations, as I said in the initial part of the program, but it was a really unusually busy week. Everybody was, running around like chickens with their heads cut off. That's a Southern kind of thing to say. But I just skipped it. I didn't do it that week. I said, well, we'll do it next week or even the week after that. So I think sometimes just being sensitive to what's going on in your agency. You can always have something planned. Keep it in the back pocket, and if everything's going well and it's been a good week, just bring it out and present it to your staff. And usually the reception is better when they're not hurried or running behind schedule and that sort of thing. So does that answer the question okay? I hope so.
Sounds great. Thank you so much, Gail.
Mm-hmm.
Our next question is from Sheila in Oregon, and this is for Cindy. Sheila says, I'm having trouble finding my data. What do I do? I think I registered, but I can't find my username and password. Is this a different website than the BPIPs? If so, what is it?
Hi, and thank you for asking that. That's a question we get quite frequently in HHQI info. Yes, the data, to access your data, it is a completely unique and different registration system than the one you created to access your BPIP. So once you click into the data site, you're basically into the data portal, which is completely separate from the HHQI site. It's all because of security. Once you're here, you must create a different user account. It is a little bit more difficult to get through because of the security aspects of it, but the one thing is, once you're through it, you're done. You never have to go through those questions again. So I encourage everyone, it really would only take about 30 to 60 seconds to register for it. It does require information from your cast for reporting. There are steps, the steps are on the application itself. It's very simple. Once you click verify, it takes about 2, maybe 3 seconds max to get verified, and you're in. If you have difficulties with it at all, and this goes for everyone, please just contact us at HHQI Info, and I'll be glad to walk you through the steps, see where you're getting held up, and if you're having any difficulties. Thank you, Shannon.
Our next question is for Ria. This question says, do you have any suggestions or lessons learned to help someone who has just started to introduce data results to our staff?
There's a very good question. I would share with them the result. You would want to choose 1 result or 2 results from the HHQI. I would choose the hospitalization rate. And I would share with them, this is not from me, this is from the HHQI, and what do you think we should do to improve this result? And that's where I would start. Did I answer the question? Sure.
Certainly. We have another question for you, Ria. This one's from Lorraine, and Lorraine asks, how does one become an integrated chronic care specialist?
Oh, okay. Our company, we attended the chronic care specialist course, which was given by PentaHealth. The PentaHealth is from Little Rock, Arkansas, and I can give you their website, which I'm pretty sure I wrote it down. Can I give it now, or should I just send it to them?
You can send it to us, and so you can send it to us, and we'll be happy to make sure and get that information to Lorraine if you like.
Yeah. Okay. I can send that, or actually I found it. It's www.pentahealth.com. So you attend the course, and you get certified after you pass the online exam.
Excellent.
So that's how we get certified. I'm sorry. Yes. Thank you.
Thank you. We have time for one last question before we wrap things up, and this question is for Misty. This person writes, we are a small agency and don't have many resources. I do think our issues are different than the other larger agencies. Will the dual eligible BPIP be more specific to us? If so, how? And we really need things that can be implemented on a small budget. Should we just use that BPIP and not the others since we have a limited time?
Absolutely not. What we're going to do is create those SPAN network calls. So what you're going to want to do is to join one of the SPAN networks that are going to be specifically for those small nonprofit organizations. We know you have limited time, but we're going to be able to give you some one-on-one guidance, even sharing through our networks, but even providing one-on-one guidance to say, okay, here's the best practice package on patient self-management. Have you read through it? Let's talk about what you're doing and how we're able to implement, even if there's implementing 1 or 2 ideas, and how you can do it on the limited resources and time that you might have. So we're going to be able to help you individualize key content, maybe not large in scope of using the whole package, but will be large to impact what you're doing at your agency. So watch for those SPAN networks, because one will be specifically for small agencies.
All right, that's all the time we have for questions today. Now with some closing remarks is Cynthia Pannon of the Centers for Medicare and Medicaid Services. Cynthia?
Thank you all again for joining us today. As we move forward, I really want to hear your feedback on what we are providing through the campaign. We actually use the feedback to improve what we do and to design future work. As a former home care nurse, I understand time is short. Consequently, we really are committed to providing you with efficient and effective tools and resources staff may actually use. Be on the lookout for upcoming webinars on various topics and join us again. Please spread the word so all home health agencies across the country may benefit from the campaign. Take care, everyone, and now I return the mic back over to Shannon Wright for final closing remarks.
Thank you so much, Cynthia, and thank you all so much for joining us on Moving Forward, the 2012 HHQI National Campaign Welcome Webinar. Please visit our website at homehealthquality.org or contact us anytime at hhqi@wvmi.org for more information and to provide your feedback. Have a great day.